All right, I think we can get started. We might get a couple last minute reporters come in. We'll try and get them in seamlessly. Dr. Van Schil, feel free to take over. Just a couple announcements for the press. We've put in the chat a couple helpful documents. Joy has included the briefing agenda that includes names and bios of everyone in the press briefing. We reposted the link to the Dropbox materials for all the press materials, slides, etc. For this briefing, as we'll do every briefing for you during the conference. Please hold your questions till after everyone's done speaking. We'll make sure that every question that you ask is answered in some way, shape, or form. If we can't get to them in the press briefing, we'll make sure we connect you with the researcher afterwards by email. Without further ado, Dr. Van Schil, take it over.
Okay, thank you. Hello, everybody, and thank you for attending this press briefing. My name is Dr. Paul Van Schil, and I'm the president-elect of the IASLC. I'm professor of thoracic and vascular surgery at the Faculty of Medicine. I'm member of the Antwerp Surgical Training and Research Center and consultant at the Department of Thoracic and Vascular Surgery at the Antwerp University Hospital in Belgium. My research focuses on thoracic surgery with an emphasis on lung cancer staging and therapy, lung metastasis, and mesothelioma. I joined the IASLC Board of Directors in 2017 and have served as lung chair of the Staging and Prognostic Factors Committee since 2017. In this press briefing, we will discuss the data presented in today's Presidential Symposium. With us is our patient advocate, Dr. Upal Basu-Roy, who will join us after the presentations. So please hold your questions, as already mentioned, for the presenters or for Dr. Basu-Roy until the end of the briefing, at which time you can ask the question live or via the chat box. Our first presenter is Dr. Melissa Johnson. Dr. Johnson is the director of the Lung Cancer Research Program at Sarah Cannon and a partner with Tennessee Oncology, PLLC in Nashville, Tennessee, USA. She supervises the lung program research program across the Sarah Cannon network and aids in the development of early phase compounds for thoracic malignancies in the drug development unit. Dr. Melissa Johnson, the floor is yours.
Thank you, Dr. Van Schil. I'd like to thank the IASLC conference president and co-chairs for selecting this abstract to be part of the press program today. On behalf of my co-investigators, it's my pleasure to present the results of the phase 3 Poseidon study of durvalumab with or without tremelimumab in combination with chemotherapy as frontline treatment of patients with metastatic non-small cell lung cancer. Here are my disclosures, all to my institution. Immunotherapies targeting the PD-1 and the PD-L1 pathway administered as monotherapy or in combination with chemotherapy have transformed the treatment of metastatic non-small cell lung cancer. While the addition of chemotherapy to anti-PD-L1 agents may provide early disease control, the addition of an anti-CTLA-4 to anti-PD-L1 may confer long-term survival benefit for some patients. In the Poseidon study, we evaluated durvalumab with or without tremelimumab in combination with chemotherapy, platinum-based, of investigator choice as first-line treatment of squamous or non-squamous metastatic lung cancer. Here's the schema for this phase 3 global open label randomized trial. Eligible patients had newly diagnosed metastatic non-small cell lung cancer without EGFR mutations or ALK alterations and a performance status of 0 or 1. They were randomized to one of 3 treatment arms according to stratification factors, PD-L1 expression using a cutoff of 50%, disease stage, and histology. Patients received either durvalumab with chemotherapy once every 3 weeks for 4 cycles, followed by durvalumab maintenance, durvalumab plus tremelimumab with chemotherapy once every 3 weeks for 4 cycles, followed by durvalumab maintenance with 1 additional dose of tremelimumab at 16 weeks, or platinum-based chemotherapy once every 3 weeks for up to 6 cycles. Investigators had a choice of 5 different chemotherapy regimen: platinum gemcitabine for squamous patients, platinum pemetrexed for non-squamous patients, or nab-paclitaxel carboplatin for either histology. The co-primary endpoints were PFS by blinded independent central review and overall survival for the durva chemo versus chemo arm. Key secondary endpoints reported today included PFS and overall survival for the durva tremi chemo versus chemotherapy arm. Here's the primary endpoint of the trial. PFS was significantly improved with durvalumab and chemotherapy versus chemotherapy alone, with a hazard ratio of 0.74 and a median of 5.5 months with durva chemo versus 4.8 months with chemotherapy alone. There was also a trend towards improved overall survival, 13.3 months with durva chemo versus 11.7 months with chemotherapy alone, but with a hazard ratio of 0.86 that did not reach statistical significance. Positive PFS for the primary endpoint allowed formal testing of key secondary endpoints, both statistically significant, shown here, comparing durva plus tremi plus chemotherapy versus chemotherapy, with hazard ratios 0.72 and 0.77 respectively for PFS and overall survival. In particular, we notice an improved separation of the curves with the addition of tremelimumab, and improvement in both the 12-month PFS as well as the 24-month overall survival landmark analysis over what was seen with durvalumab plus chemotherapy. The objective response rates were higher and the duration of response longer for patients treated with immunotherapy plus chemotherapy. Notably, 50% of patients who received durvalumab plus tremelimumab plus chemotherapy remained in response after 12 months, as compared to only 21% of the control arm. And importantly, the addition of tremelimumab did not seem to affect the exposure of patients to chemotherapy or durvalumab. There are no new safety signals. Most events were driven by the chemotherapy. While the proportion of grade 3-4 and serious treatment-related adverse events was slightly higher for the durva plus tremi plus chemotherapy arm, treatment discontinuation rates as well as deaths were similar across all arms in the trial. So in summary, Poseidon showed an improved PFS with first-line durvalumab and chemotherapy compared with chemotherapy alone in patients with metastatic non-small cell lung cancer, with a trend towards improved survival. First-line durva plus tremi plus chemotherapy also demonstrated a statistically significant improvement in both PFS and overall survival. Sorry, I lost my place. First-line treatment with durva plus tremi plus chemotherapy also demonstrated a statistically significant improvement in both PFS and overall survival versus chemotherapy, especially among non-squamous patients and patients with PD-L1 less than 1%. The safety profile was similar to previously reported accounts of immunotherapy and chemotherapy, with no new safety signals identified with the addition of tremelimumab. Therefore, durvalumab plus tremelimumab plus chemotherapy represents a potential new frontline treatment option for patients with metastatic non-small cell lung cancer. Thank you.
Thank you, Dr. Johnson. You may stop screen sharing now. Our next presenter is Dr. Luis Paz-Ares. Dr. Paz-Ares is currently chair of the Medical Oncology Department at the University Hospital, associate professor at Complutense University, and head of the lung cancer unit at National Oncology Research Center, all in Madrid. He's president of the Spanish Association for Cancer Research. Dr. Paz-Ares.
Thank you very much, Paul. Thank you very much. I'd really like to thank the press committee for allowing me to present on behalf of all the Atlantis trial investigated the results of this phase 3 trial of lurbinectedin plus doxorubicin as compared to the standard of care chemotherapy, CAV or topotecan, for relapsed small cell lung cancer patients. Here are some of my disclosures. I mean, small cell lung cancer is the more aggressive form of cancer, of lung cancer actually. Is typically linked to tobacco smoking and accounts for about 13% of the cases. So you may do the counts. We have more than 2 million new lung cancer every year. So that means close to 250 to 3,000 new cases of small cell lung cancer. This is a very aggressive cancer, very often metastatic or radial diagnosis. And something on the good side is that it's very sensitive to chemotherapy, very responsive, also to radiation therapy, but typically response lasts very short because relapse is typically coming after some few months. Unfortunately, even we have learned a lot about the biology, the genomics, the transcriptomics of this disease. We were not that successful over the last 2 decades in having new treatment options in this disease. Some effect of immunotherapy, but still, particularly for relapsing patients, very few treatment options. Lurbinectedin is a drug which is FDA approved based on a single-arm trial. This drug is actually a minor group binding of the DNA. Is derived from a marine tunicate, and in relapsing small cell lung cancer, produce a response rate in the range of 34%, being higher in patients with sensitive disease, 45% as compared to those resistant disease. Based on those data, a trial, single core, the drug was approved by the FDA. But there are some other data I really like to notice to you, which are the combination of lurbinectedin plus doxo. That was an initial trial with some responses in 40 to 60% of the patients on a phase 1 combination trial. So based on those data, that was the combination at the time chosen to go into a phase 3 trial. Phase 3 trial, of course, for patients with small cell lung cancer with one prior treatment with chemotherapy. Also one PD-1, PD-L1 therapy was allowed. And patients need to have good PS and measurable disease. And patients, so more than 600 patients, were randomized to standard of care topotecan of CAV chemo versus the control arm, doxorubicin plus lurbinectedin at the doses that were found in the initial phase 1 trial. And of course, overall survival was the main endpoint of this trial. Some secondary endpoints were, of course, safety and PROs and so on. As you see here, there were no, the trial didn't meet the primary endpoint. There were no difference in survival between the two treatment arms, as you see by those superimposable curves. Hazard ratio being 0.97, that was not statistically significant. There was, however, some improvement in PFS with a hazard ratio of 0.83. That means decrease in the risk of progression over the time in about 17%. But of course, was not enough to actually impact on survival. On the more positive side, the safety profile of the experimental arm was much better, particularly in terms of myelosuppression. There were at least reduction in half on the rates of grade 3 or 4 anemia, 14 as compared to 31, neutropenia 37 versus 69, or thrombocytopenia 14 versus 31%. More importantly, there was a reduction by half in the rate of febrile neutropenia, let's say, likely the more severe type of toxicity in this setting. Non-hematologic toxicity, there were not big differences. So altogether, better toxicity profile, as you see here, less deaths also, less serious adverse events. So altogether, I think we have to conclude that we didn't see an improvement in efficacy. The trial didn't meet the primary endpoint. But we confirm the safety profile, even adding doxorubicin to lurbinectedin was somehow better, particularly in terms of myelosuppression as compared to standard of care. More importantly, I would say, is that new combinations of this agent, lurbinectedin, and cytotoxic agent or immunotherapy are actually being explored in this setting. Just to give you a hint of the data, initial trial from our group show a response rate of 62% when combining lurbinectedin. Yeah. And I think that's something we should look forward to continue those studies and maybe getting them into the phase 3 setting.
Okay, thank you, Dr. Pasares. You can stop screen sharing now. Our third presenter is Dr. Nasser Al-Torki, an international renowned surgeon. He's chief of the Division of Thoracic Surgery at the New York Presbyterian Hospital and is a David B. Skinner Professor of Cardiothoracic Surgery at Weill Cornell Medical College. He's also the leader of the Experimental Therapeutics Program at the Sandra and Edward Meyer Cancer Center and director of the Neuberger Berman Lung Cancer Research Center. Dr. Al-Torki.
Thank you, Dr. Van Schiel. Let me just share my slides here for a second. Can you see my slides?
Yes, yeah, we can see them. Thank you.
Okay, sorry. Okay, so I am very appreciative of the organizers and the IASLC for allowing us to present our results on Empower 010 after the ASCO presentation. And I'm privileged, of course, to do this on behalf of all the investigators. These are my disclosures. As you all know, the treatment of choice for patients with stage 2-3 non-small cell lung cancer is surgical resection, followed by adjuvant chemotherapy. That is the standard of care for resectable patients. Dr. Wakely had presented the top line results of Empower 010 at the ASCO meeting and showed that adjuvant atezo provided superior survival compared to best supportive care in the category of patients that are PD-L1 positive and had stage 2 to 3 non-small cell lung cancer. The statistical significance boundary, however, was not crossed for the ITT population, which included patients with stage 1B, and the overall survival are still immature. The purpose of this presentation was to look at the impact of prior therapies, surgical therapy, chemotherapy, and various disease stages on disease-free survival in this trial. Just as a reminder, the overall design, patients who had completely resected stage 1B to 3A non-small cell lung cancer were enrolled, but not randomized, enrolled and then went on to receive 1 to 4 cycles of cisplatin-based chemotherapy or cisplatin-based chemotherapy, and then randomly assigned to receive adjuvant atezo for 16 cycle or best supportive care. There was a hierarchical statistical design in which we looked at the primary endpoint of disease-free survival first in the target population of PD-L1 positive stage 2-3A. And if positive, we would look at the disease-free survival in all stage 2 to 3A. And if that was positive, we would look at disease-free survival in the whole population, which included stage 1B. And a secondary endpoint would be for overall survival. So there were 1,280 patients that were enrolled, and then 1,005 that were subsequently randomized. So 275 patients were not actually randomized. The main reason was withdrawal of consent by subjects. You know, patients going through 4 cycles of chemotherapy, probably most of them have decided that they've had enough. The interesting thing is that disease relapse was the cause in about 20% of patients. And adverse events as a result of prior therapy or death prior to randomization combined accounted for another 20% of patients who withdrew, who were not able to proceed to randomization. This shows the distribution of the various demographic disease stages and therapeutic characteristics between the 2 arms of the trial. And they were well balanced between the 2 arms. More specifically, About 80% of the patients in the atezo arm and in the best supportive care arm had mediastinal node dissection. Lobectomy was the most common form of operation done in both arms with an equal frequency, roughly 77% and 78%. The median time to the receipt of adjuvant therapy or best supportive care was about the same between the two arms of the trial. And the cisplatin-based doublets were equally represented between both arms. The most common was cis-pemetrexed and cis-vinorelbine. This slide shows that overall, there was very good compliance with the receipt of 4 cycles of chemotherapy. This was slightly lower in the patients that had cis-gemcitabine, but still about 78 and 77% received the prescribed 4 cycles of chemotherapy. These Kaplan-Meier plots show the top-line results that were presented before. On the left side, you can see that there is a significant improvement in survival of PD-L1 positive stage 2 and 3A non-small cell lung cancer. The median disease-free survival was not reached in the atezo arm and was 35 months in the best supportive care arm. The hazard ratio was 0.66 and the p-value was 0.004. The middle panel shows the survival, the DFS in all randomized stage 2 and 3A patients. And again, there was a superior survival in the atezo arm with a median disease-free survival of 42 months versus 35 months and a stratified hazard ratio of 0.79 with a p-value of 0.02. On the right, you see the DFS in the ITT population that includes stage 1B, and it appears from the curve that there is a better survival in the atezo arm, but I remind you that the significance boundary was not crossed, so this analysis awaits the final DFS analysis. We then did an exploratory analysis to try and understand the impact of prior therapies for the purpose of this presentation. This looks at a forest plot of the disease and various treatments on DFS in the target population of that is PD-L1 positive stage 2 and 3A. And in general, what is noticed here is that there's a significant advantage in DFS that favors the atezo arm. When we did the same exploratory analysis in all randomized stage 2 and 3A, again, across disease stages, surgical therapy, and chemotherapy combination, all those, there was the atezo arm was favored in DFS across all categories, or mostly all categories. And then when we did the same exploratory analysis for the ITT, again, this still awaits the final analysis of DFS, but there is a general trend favoring the atezo arm, again, across all disease stages and surgical therapy, as well as various chemotherapy combinations. So in conclusion, at the DFS interim analysis, atezo showed a statistically significant DFS benefit over best supportive care in the target population of PD-L1 positive stage 2 to 3A and in all randomized stage 2 to 3A. In the IIT, in the whole population, the majority of patients appear to have had good surgical therapy. They had lobectomy, lymph node dissection, and 4 cycles of adjuvant chemotherapy. The median time to the initiation of best supportive care or atezo was similar. The study arms were well balanced with respect to disease stages, regional nodal status, surgical intervention, and chemotherapy regimens. In this exploratory analysis, benefit with adjuvant atezo versus best supportive care was observed in the target population of PD-L1 positive stage 2 to 3A across most disease stages, including patients with nodal disease, various surgery types, and chemotherapy regimens.
Okay, thank you very much, Dr. Altorki. You may stop screen sharing now. Our next presenter is Dr. Christine Burke. Dr. Burke is a special volunteer to the Director, Division of Cancer Epidemiology and Genetics, National Cancer Institute of the National Institutes of Health. Her research efforts focus on cancer risk-based assessment and how to integrate molecular epidemiology and then move these efforts into the clinical arena. Here she presents research on behalf of herself and her co-author, Dr. Joan Schiller. Dr. Burke, please.
Can you see my slides?
Yes, we can
Okay,
see
great.
them clearly. Thank you.
All right, fine. I very much appreciate the program committee's selection of my presentation for the plenary session, and also I appreciate the selection for this press conference. Dr. Schiller and I are forming a nascent group, Oncologists United for Climate and Health, and are learning a lot about problems with environmental toxins worldwide. Air pollution has recently been reported to lung cancer is attributed to air pollution in 14% of cases across the world. And we felt that this was an issue that was not well discussed at IASLC and was really important for our patients, both for disease causation and also survival. If you do develop lung cancer, your survival is worsened with exposure to air pollution. So we looked into it further, and I was very surprised. I went to a database that is from the Global Burden of Disease, the Institute for Health Metrics and Evaluation, now well known to us because of their coronavirus predictions. And I looked at the distribution worldwide in two age groups, ages 50 to 69 and 70 plus. This is the deaths from lung cancer attributable to particulate air pollution. And the top country in the world, which came as a surprise to me, and I think many, is Serbia, actually. Both cigarette smoking is intense there, and air pollution, primarily from coal-fired energy production, is intense. And Poland is also a problem with smoking and their coal-fired pollution. China is an issue as well. Interestingly, as the population ages, China is more of a problem. Mongolia is also a problem as well. So 14% of lung cancers are related to air pollution, a problem for all of our patients. As I mentioned in the Q&A discussion earlier, I think we need to address many sources of air pollution and greenhouse gases, starting with coal. Here are the percent of energy production from coal across some of the countries mentioned in my abstract. In the US, we're down to 19%, but unfortunately, a lot of coal has been replaced by natural gas. Natural gas is actually methane, which in and of itself is toxic, which is why producers add that rotten egg smell to it so you don't breathe it in too much. And we need to switch instead to clean energy sources rather rapidly. And I think this is incumbent upon us all. So my take-home message is that we have a problem for our lung cancer community, both for our patients who are at risk and also for those in the future. We need to address sources of air pollution, fossil fuel plants, transit, and indoor cooking modules. Air pollution is actually worsening. We're all familiar with the horrendous fires that affected Australia. We had fires this summer in Turkey. We still have fires raging out in the West. My sons live in San Francisco and South Los Altos. They check their air quality index every day to determine whether or not they should wear an N95 mask to just even go outside, let alone interact with people to prevent COVID. And this is a real issue. So we need to rapidly address, we need to double down on smoking rates, and we need to rapidly address air pollution. Really incumbent upon all of us, healthcare professionals, journalists, us as planetary citizens. We can mitigate the effects of air pollution and causing lung cancer by speaking out for clean energy standards and in our own choices in our homes and in our communities. And I really want to urge rapid action.
Okay, thank you, Dr. Berg, for your very clear messages to all of us. And you may stop screen sharing now.
Let me find the button.
Yes. Our last presenter is who's all dealing with a very interesting topic is Dr. Matthew Smetzler. He's an associate professor of epidemiology and biostatistics. He's an active member of both the IASLC and the NIH-funded Sickle Cell Disease Implementation Science Consortium. Dr. Smeltzer is also principal investigator of the Tennessee Sickle Cell Disease Surveillance Program, funded by the Centers for Disease Control and Prevention. Additionally, he is the quantitative lead for the NIH-funded Mid-South Quality of Surgical Resection lung cancer cohort. Dr. Smeltzer.
Thank you. Let me get my screen sharing going here. Okay. Thank you for the opportunity to share this abstract and the press conference today. We, a group from IASLC, wanted to study the impacts of COVID-19 on international lung cancer clinical trials. And so we put together a survey to try to understand better how the COVID-19 pandemic impacted clinical trial enrollment across the world in 2020. And so we took a two-pronged approach to this. We first wanted to just collect enrollment data across the world for as many clinical trials in lung cancer as we could collect. And we did this based on number of enrollments by month for open trials. And we did this for 2019 to provide some type of baseline comparator and for all of 2020. Then we did an action survey where we tried to get one response per site that conducts clinical trials for as many sites as possible across the world and ask what happened at your site in terms of lung cancer clinical trials during the pandemic. What challenges did you face specifically, and what did you do to try to mitigate those challenges, and did you think it worked? So overall, we received data from 173 clinical sites and a total of 171 clinical trials in lung cancer from a total of 45 countries. You can see the regional distribution on this graph here. And so we first looked at our enrollment data, and this graph shows the total average monthly enrollment for open trials in 2019 in the blue bars, and average monthly enrollment for open trials in 2020, which are the red bars. And also the dotted gray line shows the total number of COVID-19 diagnoses per month globally. And you can see that the largest gap in enrollment from 2019 to 2020, so where the red bars and the blue bars are the most discrepant, was at the beginning of the pandemic in April to August. But we see by September to December, the gap starts to close quite a bit. And it looks like relative to 2019, monthly 2020 enrollment started to rebound, despite the drastic increase in total COVID-19 cases diagnosed each month across the world. So we asked the sites, what challenges specifically did you face from the pandemic, and looked at the proportion of sites that felt this was a significant challenge or greater. So fewer eligible patients was the most frequent response. It's followed by challenges with protocol compliance. Many trials were suspended, and so that was a challenge. Availability of research staff was a major challenge, and institutional closures. So these are all challenges that were sort of at the institutional level. We then asked what challenges patients faced, and just a willingness to visit the site for clinical trial activities was a major challenge. The ability to travel or access to the trial sites were major challenges. Exposure-related quarantine or actual COVID-19 infection were also major challenges that were faced. The patients were concerned about fear of COVID-19 infection from participation and travel restrictions, as well as just securing transportation and being able to access labs and radiology. So what did sites do to try to mitigate these challenges? So we asked them what were the most frequent mitigation strategies that they used. What did they do to try to improve the conduct of the trials in terms of enrollment and compliance? So modifying monitoring requirements was the #1 response, followed closely by telehealth visits. So allowing telehealth visits and clinical trials was a major mitigation strategy. Also allowing labs at non-study facilities, modified required visits, mail order medications, radiology at non-study facilities, altering trial schedules altogether, and then to a lesser extent, electronic consent and altered consent processes were used to mitigate the challenges that were faced. So we then asked them what were the most effective strategies in your opinion, and telehealth visits, remote diagnostics, remote patient-reported symptoms, and remote consenting were thought to be effective at mitigating the impact of the pandemic on clinical trials, indicating providing more flexibility in place. And delayed assessments, IRB changes, and delayed visits were also felt to be very effective, indicating a flexibility in time. So overall, we think a more flexible approach to clinical trials could include allowing telehealth visits from both research staff and physicians to help clinical trials move forward, allowing local testing, including labs and scans more locally when possible, mailing experimental agents when we can would really help, and flexible alterations in trial schedules. So overall, a more flexible approach, removing unnecessary barriers, may improve enrollment and access to clinical trials even beyond the pandemic. So we think there's some good lessons learned here as far as what rigor do we need to maintain the value and the quality of clinical trials versus what flexibility can we increase to make trials more feasible, more accessible, and more patient-friendly. And I'd like to thank the executive committee and steering committee, who a lot of people contributed a lot to this project, and appreciate all those efforts.
Okay, thank you very much, Dr. Smeltzer. It's now my great pleasure to introduce our patient advocate, Dr. Upal Basu-Roy, who is the Vice President of Research at Longevity, a lung cancer patient advocacy organization, and a former mentor in the IASLC STARS Patient Research Advocate Training Program. Dr. Basu-Roy will be providing comments on the discussed science through a patient advocate lens. Dr. Basu-Roy, please.
Thank you, Dr. Van Schil. Unfortunately, I'm unable to share my slides, but while that's being taken care of, I just want to tell everyone that it's an immense pleasure and privilege to provide the patient advocacy perspective to today's 5 excellent plenary presentations. And unfortunately, I'm still unable to share my slides.
I think Chris or Joy can show your slides if you send them in advance.
That's fine.
Yeah.
You should be able to do it now. I've made you co-host. Try again.
Wonderful. Thank you so much. All right. I have no disclosures related to the presentation. And before I actually provided the advocacy perspective, I just wanted to sort of set the stage for why the plenary session today was hugely important from the advocacy perspective. And this is just the patient journey. And I think everyone on this call is pretty familiar with the patient journey, right from starting from pre-diagnosis or individuals at high risk, followed by diagnosis. And then, of course, there's a bifurcation by histology. And today's plenary talks touched upon very, very important aspects of the patient journey, and sort of tying it all together was Dr. Smeltzer's presentation on the impact of COVID-19 on lung cancer clinical trials, because clinical trials impact every aspect of the patient journey. And I'll be discussing I'll be providing my perspectives not in the same order as Henry and sort of sticking to the patient journey. And the first abstract that I want to provide my perspective on is the one provided by Dr. Berg from the United States, which is the global variability in lung cancer deaths attributable to air pollution. And I think this is becoming hugely, hugely important for the lung cancer community. And I think, as all of us know, tobacco exposure is one of the biggest risk factors of lung cancer. But we also know that smoking rates are starting to decline, but lung cancer rates continue to increase. And it's time that we started investigating other causes of lung cancer. And Dr. Berg makes a very, very good case on why it's a balance between air pollution, specifically particulate matter in this case, and adult smoking. And so essentially, these are the two biggest risk factors right now attributable leading to lung cancer, both tobacco exposure as well as air pollution. And as Dr. Berg pointed out, I think we as a community, we need to be focusing on mitigating both these risk factors if we are really going to think of lung cancer prevention. And I think this particular presentation also highlights the importance of other causes of lung cancer, specifically lung cancer in never smokers. And why this matters, I think this matters incredibly because, as Dr. Berg pointed out, and as well as the discussant, the biggest burden of air pollution is shared by low-income and middle-income countries, and they will also be sharing the biggest burden, the biggest economic impact of lung cancer deaths from pollution. And what you see in that figure is essentially years lost to disability, specifically in females between the ages, actually all age females. And what you see in 1990 and what you see in 2019, you can see that years lost to disability, it's increasing with time. And most of that increase, and when you see a line that's going upwards, that's actually an increase. Most of that increase that you see in years lost to disability is actually being seen in low-income and middle-income countries. So this is really the time to think globally and act locally, as Dr. Berg pointed out. The other piece why this abstract is incredibly important is the fact that pollution-driven lung cancers tend to have a very distinct biology, and that biology will be impacting treatment. And what I have shown here on the right side is a very recent publication that came out of the NCI, which is looking at lung cancer in never smokers. And the figure here is specifically looking at the genomic signature of lung cancer caused because of exposure to diesel fume. And this signature is fundamentally different than lung cancer caused due to active tobacco exposure. And the other piece to keep in mind is the presence of actionable driver mutations tend to be higher in this group. So the second takeaway here is social determinants of health matter, where the patient lives matter. And I think it's important for oncologists to keep that in mind when they're discussing treatment strategies with their patients, where the patient lives, how that impacts lung cancer causation. The second abstract that I'll provide perspective on is the one provided by Dr. Al-Dorki from the United States again, and on the Empower 010 study. And again, this is a very, very seminal study because this is the first study looking at the role of immunotherapy in the adjuvant setting. And just again, to set stage for everyone in this discussion, what you see on this particular slide is essentially the role of adjuvant therapy in non-small cell lung cancer where we were. And as comparison, what I've shown here is adjuvant therapy in breast cancer. And as you can see, adjuvant therapy in breast cancer has made remarkable progress over the past 20 years. And we've not seen that kind of progress in adjuvant therapy for non-small cell lung cancer. And this is somewhat reflected in the 5-year overall survival rate for both these diseases, with lung in 63% and obviously a much better survival rate for adjuvant breast cancer. And part of this is definitely attributable to the presence of various treatment options as adjuvant therapy for breast cancer. So keeping this landscape in mind, this particular abstract was asking a very, very important question. Now we have adjuvant platinum-based chemotherapy to offer to this group of patients to stage 1B, stage 3 in non-small cell lung cancer. But we see a very, very modest improvement in overall survival. So the question here is the addition of immunotherapy going to lead to better outcomes? And yes, it does. The survival curve on the right, on the left, clearly shows that there's a very nice separation in disease-free survival between those patients who received immunotherapy as an adjuvant therapy versus those who received standard of care. And this particular abstract was also presented at ASCO this year by Dr. Heather Wakely. And based on the results of the Empower 010 study, the US FDA granted priority review to atezolizumab for the adjuvant treatment for a subset of early stage non-small cell lung cancer. And Dr. Altorki's abstract actually made some very, very important points from the patient perspective. The first point was that the study arms are well balanced, which I think is incredibly important to keep in mind, because that just tells us that this effect that you see cannot be attributed to disease heterogeneity. The other piece, which is actually even more important, is that most patients had very similar standards of care: lobectomy, lymph node dissection, and 4 cycles of adjuvant chemotherapy. And there was also a range of different chemotherapies that were used as the chemotherapy piece in this trial, which again tells us that this effect cannot be attributed to practice heterogeneity. To practice heterogeneity, what I mean by that is different surgeons doing different things and the choice of chemotherapy. So point number 2 is incredibly important from an implementation perspective. And the last piece, of course, is that median time to surgery to start of therapy was not affected by the addition of IO as an adjuvant therapy. And again, that's important to communicate to patients that adding IO does not change adjuvant therapy. So then this brings me to sort of the final comments on this particular abstract, adjuvant therapy. How do we strike the balance? On one hand, where do we go? Do we go with adjuvant therapy or neoadjuvant therapy? And that seems to be a big discussion in the community. But keep in mind that from the patient perspective, what really matters is what is the right therapy for them. DFS, is disease-free survival enough for a regulatory approval? And this is a huge discussion that has been going on in the adjuvant therapy space. But again, keeping in mind the patient perspective, is it fair to wait for overall survival, which takes a much longer time to read out in an adjuvant trial, when we are seeing early on benefits with DFS as the primary endpoint in an adjuvant trial? Is it ethical to withhold those treatments from patients while we wait for overall survival? And the other piece, of course, which is incredibly important to keep in mind, is side effects. Whenever we think of immunotherapy, we need to keep in mind long-term and late onset side effects, and that's not something that's captured within clinical trials. And last but not least, patient preference, patient heterogeneity, and patient selection. What do patients really want? I think we need to have these discussions with them. And patient selection, does everyone get the chemo-IO combination, or is it a subset of patients who will benefit from this treatment? Which is actually a great segue to the third abstract, which was presented by Dr. Johnson on the Poseidon study. And again, the study was basically looking at this particular question: can we push the survival needle by adding a CTLA-4 inhibitor to a chemotherapy and PD-L1 regimen? And of course, in terms of the trial was successful. As you can see here, the overall survival is significant at 24 months, which is great. But I do want to point out the figure that I'm showing you on the right side, which is looking at AEs. And this is a very, very important piece from the patient perspective. Yes, I think from a clinical trial perspective, when we don't see grade 3-4 toxicities, that's great. But from a patient perspective, it's important to keep in mind that any grade is important. And this is what I would encourage everyone to think of, that when we are thinking of these types of regimens, we need to keep in mind the overall AE profile, because that's what's going to impinge on a patient's quality of life. And of course, based on the Poseidon study, the suggestion is that durva plus tremi plus chemotherapy is a great potential new option as first-line treatment for non-squamous metastatic non-small cell lung cancer. Which then brings me to this point, and this is incredibly confusing, both from a patient perspective and also from a treating physician perspective. We have a lot of choices for first-line treatment of metastatic non-small cell lung cancer that do not have driver oncogenes. And this is just a snapshot of that. This is sort of setting stage on what these different options are and where the subdivisions happen. Now, the question that we need to ask ourselves is, are we just adding Poseidon to this armamentarium already as just another option? And which then brings me to the patient perspective piece, is how do we strike a balance for the role of first-line immunotherapy for metastatic non-small cell lung cancer? Do we go with the chemo or the IO chemo route? Or do we go with the IO route? Because a lot of patients, they are interested in having chemo-sparing regimens. Is it just the histology that is the determinant of prescription? And cost and access, how do we discuss that? In the previous slide, you saw that we have all of these amazing options as first-line treatment, but how do we balance the cost and access discussion? And on the other side, equally important are the side effects, again, long-term and short-term and late onset side effects of all of these regimens. Patient preference, patient heterogeneity, and patient selection are, I think, going to be incredibly important. And again, from the patient perspective, what is the role of the clinician preference in these discussions? And keeping in mind that the selection of therapy should not be put on the patient. That's not a burden that the patient should be shouldering in these discussions. The fourth abstract that I'll provide commentary on was discussed by Dr. Pazares from Spain, and it's looking at the role of LERBI and DOX as a treatment option versus CAV or topotecan in relapsed small cell lung cancer. And this is the Atlantic trial. And again, this is a huge unmet need in the small cell lung cancer space. I think all of us can agree that we have not made a lot of progress in the treatment of small cell lung cancer. And based on the data presented by Dr. Pazares, the trial was not successful. As you can see on the overall survival curve to the left, the trial did not meet the endpoint of overall survival. But what I think is important for us to keep in mind from the patient perspective is when you're looking at duration of response, you do see a separation of curve. So possibly the LERBI-DOX combination does give you a more prolonged response in a subset of patients. And equally important is the AE profile. The LERBI-DOX combination had a much, much better AE profile as compared to CAV or topotecan. And that is important to keep in mind from a patient perspective, the side effect profile. Are we only thinking of overall survival? And side effect profile is equally important. Which then brings me to, why does the Atlantis study matter? It matters hugely for the small cell lung cancer community. First of all, here is a drug. LERBI is a great drug. It has a low AE profile, and it has a unique mechanism of action. So LERBI would be a great partner to combine it with other drugs, given its very, very favorable AE profile. And we did see that there was a potential role for this combination for a subset of IASLC patients whose tumors progressed greater than 180 days from the initiation of first-line treatment. Now, what about some of the negatives? Again, from a patient perspective, we did not see this particular trial move the needle enough. And it's still not clear what's the impact of the first-line IO chemo combination on the response in the second-line setting of this combination. And of course, this particular trial raises some very, very good questions from the patient perspective. What is the role of combining LERBI with immunotherapy? And is there a role of biomarkers in the second-line setting to predict which patients will respond to this combination? And that brings me to the final abstract that I'll be commenting on, which was presented by Dr. Smeltzer from the United States, which is looking at the impact of the COVID-19 pandemic on lung cancer clinical trials. And as Dr. Smeltzer pointed out, there was a sharp decline in trial recruitment from 2019 to 2020, and this impact was the most dramatic in the early phases of the pandemic, as would be expected. And then, as he explained, there was an increase in trial enrollment towards the second half of the year. And of course, that situation is probably going to change right now with the Delta variant and with vaccinations. But all in all, his study clearly highlights that some of the mitigation strategies that were employed by trial sites did lead to an increase in patient enrollment. What I found particularly helpful in this particular study was the impact of low trial enrollment on patients and some of the challenges that they faced during the pandemic. And what you see on the left side is essentially the challenges that patients faced and some of the concerns that they had. And these are all very legitimate concerns. And what you see on the right are the mitigation strategies that the different trial sites employed. And I've specifically highlighted in orange those particular mitigation strategies that were particularly beneficial to patients to mitigate, to decrease their anxiety. And this brings me to the final slide for this particular abstract, which is, what can we learn from the pandemic to make future clinical trials more patient-centric? And Dr. Smeltzer ended on this note, and he used a very nice framework on describing how flexibility in place and flexibility in time both sort of had a synergistic effect in increasing trial increasing trial recruitment. But from a patient perspective, is that enough? And this is where I would sort of challenge everyone on this discussion that, yes, some of those mitigation strategies are very, very helpful. And as you can see, telehealth visits, remote diagnostics, remote monitoring, modified symptom monitoring, hugely beneficial from a patient perspective because they reduce the impact, they reduce the patient burden on clinical trial participation. But on the other hand, flexibility in time, delayed visits, delayed assessment, IRB changes, these all delay recruitment from the patient perspective and of course leading to more patient burden and heightened anxiety. So then to summarize, what I would like to conclude this discussion with is how amazing the 5 talks were in really, really sort of advancing lung cancer patient care across the entire lung cancer continuum. And again, thank you very much for allowing me to present the patient perspective. And thank you to all the leaders for your commitment to serving the lung cancer community, and enjoy the rest of the conference.
Okay, thank you very much, Dr. Bazuroy, for the patient perspective. And we are now going to the questions. And I see that there are several already in the chat box. So we take them in the same order. We start with Dr. Johnson and the Poseidon study. So one of the questions is, when will the triplet, so the combination immunotherapy, become available? I think that was also during the Presidential Symposium asked to you.
I think what I understand from, because I don't work for AstraZeneca, is that there are discussions underway with regulators. So stay tuned.
Okay. Another question also from Caroline Helwig from ASCO Post was, how is it possible that toxicity was not increased with the addition of 2 checkpoint inhibitors?
So Caroline, you're a doubter, I guess. In fact, you know, that was actually one of the main focuses of Poseidon, right? When we launched this trial, the question was, could you add an anti-CTLA-4 to a PD-1 and chemotherapy? And could you balance both the potential immunosuppressive effects of chemotherapy, maybe suppressing the very cells that you're trying to stimulate with the immune therapy. But the other focus of the trial was safety and could it be done safely? And that was one of the reasons for only 5 doses of Tremi rather than ongoing. And it was the reason for only 4 cycles of chemotherapy. So, you know, I look at treatment discontinuation rate. It was the same, around 14 or 15% across all 3 arms of the trial with immunotherapy, Durva or Durva-Tremi, and chemotherapy. And the rates of death on the trial were also very similar. And maybe finally, I'll point out that our data was compared very similarly to the other trial, Checkmate 9LA, that combines chemo with Nivo and Ipi, where treatment discontinuation rates were about the same. So I guess to answer your question, yeah.
Okay. I have another question from Catherine Caruso from Cancer Discovery News. Could you comment on the clinical significance of the Poseidon results for the moment? So what we now know is that, what is the clinical significance at the present time?
Sure. So I think this is a potential new addition to the armamentarium that we have to consider. As Dr. Bramer mentioned in her discussion, we tend to use PD-L1 to decide whether a patient will be best served with a monotherapy checkpoint approach or chemotherapy and checkpoint inhibitors. In the subgroup analysis based on PD-L1 level, which I included in the presentation this morning, but didn't have time to include in the press meeting here, patients with all levels of PD-L1 with a cut point of 1% and a cut point of 50% benefited from the addition of immunotherapy to chemotherapy, in particular for PD-L1 high. But if you look for patients that receive tremelimumab in combination with durvalumab plus chemo, that did lessen the hazard ratio in favor of more survival benefit. for patients with PD-L1 low tumors. So if I had to tell you what the clinical significance may be in my clinic, I could see using this regimen for patients with PD-L1 low expression of their lung cancer.
Okay, I think I agree with that. In Europe, we are always lagging a bit behind. So it will take a longer time before this treatment will be reimbursed in Europe. But I think indeed, as you mentioned, there will be some patients group who probably will benefit from this treatment. We move on to the Atlantis trial. Dr. Paz Ares. I have a question from Christina Bennett. Could you comment why you think the trial failed? Will lurbinectedin continue to be studied in combo at a dose of 2 milligrams per square meter, or is a higher dose being considered, given that single agent use is 3 milligrams per square meter? So two questions, the dose and combination therapy.
Okay, so in terms of the reason for failure, the main reason likely is because this is a very difficult disease. We have been doing a lot of trials over the last 2 decades, and one after the other had been really not positive. It's really difficult to impact on OS in the relapsing setting. We now know that this disease is very dynamic in the biologic evolution and is becoming really resistant, and in resistant disease is really difficult to tackle therapeutically. Anyway, we have seen some hints of activity. If we were to start the trial today, likely we wouldn't go with lurba plus doxo. We are not sure about the addition of doxo to this combo. We know that we are actually not able to give full doses of lurbinectedin. So, in that sense, the activity of lurba alone is at least as good, and of course, the toxicity would be much better. In terms of combinations, we are now trying a number of combinations. Particularly, my group has been involved in 2 combos. One with irinotecan. The initial data are really promising. Response rate 62%. PFS for those patients in the trial was actually longer with the second line irino plus lurbe as compared to the first line platinum etoposide in that particular cohort of patients. And of course, the combination with atezolizumab and other PD-1 inhibitors is also very attractive. The drug itself is able to reshape the microenvironment to a more immunogenic one. And the initial data with PD-L1 inhibition in combination is really good. And those data will be released within the next few months in a coming meeting.
Okay, thank you very much. We have another question for you from Ian Ingram at MedPage. Today, does a similar survival with lurbinectedin, doxorubicin plus lower toxicity suggest that this could be an option in the second line setting? Would you recommend this to patients?
Well, honestly, I think this trial showed that doxo plus lurbe is as effective. There were, as being highlighted here, some increase in PFS and duration of response, particularly in sensitive disease patients. But more importantly, the true gain is in terms of toxicity. Myelosuppression is reduced by half, the relevant myelosuppression. And anyway, being honest, because the drug is being approved in the second line setting as single agent, we haven't compared single agent versus lurbe plus doxo at the present stage. Given the data we have and given the tox profile, I would use lurbe single agent as compared to the combo. Before they asked me one question that they didn't answer, sorry about that, which is about the dosing in the combinations. We are actually trying to push up the dose, but of course, we have to do that to a point is feasible. For example, with irinotecan, which is a topo-1 inhibitor as well, I'm not sure we're going to be able to deliver 3.2 with significant doses of this other irinotecan. Maybe with immunotherapy is going to be easier, but not with irinotecan for sure.
Okay, thank you, Luis. We move to the Empower 010 study. I have a question here, Dr. Altorki, for you. Considering that it seems virtually that every patient subset benefits, are there any patients who would not be candidates for a TISO approach?
Well, thank you for
With
that.
undernote negative ones, or?
Yeah, thank you for that question. So, before we do the final DFS analysis, it's hard to make predictions about stage 1B disease. It appears that in the end may prove to be beneficial, but I think that the big point here from the point of view of a lung cancer doctor is the significant difference in survival in patients who have stage 2 and 3 disease, particularly those that have node positive disease. We're faced by those patients, and we know that adjuvant chemotherapy, although it may improve their survival some, that improvement in survival is at best moderate, and we're always looking for options that would further enhance their survival. And I think it is quite likely that DFS advantage will translate also to OS advantage. So if nothing else comes out of this, I think we have a great move forward here.
Okay, thank you. I see no other questions, I think, for you. So that was all very clear. Then we move to the presentation of Dr. Berg. No specific questions. Yeah, I think your messages were very clear. Thank you for that.
Thank
Dr.
you.
Van Schil,
Yeah.
we did get two questions about, for one for you and one for Dr. Smeltzer, about the Delta variant and how it might impact clinical trials in lung cancer.
That's for the last one, I think. Yeah.
Yeah.
That's our last presentation. Is Dr. Smeltzer. Yeah, the Delta variant. We participated in the survey. At that time, we didn't have a real problem with the Delta variant, which is now emerging. And as I mentioned at the beginning to my colleagues, we are now increasing the number of intensive care beds because of the Delta variant and people going to the ICU. Most of them are not vaccinated or had only one vaccine. Dr. Smeltzer, do you agree?
I do. I think it could intensify some of the challenges that we found in the survey in 2020, the being more contagious as well. It looked like quite a few of the concerns from patients were around, staying safe from the virus. And so I also wonder if we're going to see more regional discrepancies in enrollment. Some regions might be affected more than others now with the Delta variant, but I do think the mitigation strategies that seem to work in 2020, that some of those will continue to help. And I don't think we'll see as large of a drop as we did just at the beginning of the pandemic. Because I think the survey tells us people have figured out how to work around the challenges and how to make things work at their sites quite a bit. But there's obviously some challenges that we'll have to wait out, some things we won't be able to overcome.
Okay, thank you. We are running a bit late, but I have here the final question, also from Caroline Helwig on the Poseidon trial, whether the other medical oncologists on the panel can comment on what they think is clinical significant. Luis, you want to comment?
Sorry, I didn't hear the question. Sorry.
Yeah, the question is on the Poseidon trial, so presented by Dr. Melissa Johnson. What is your opinion regarding the clinical significance?
Well, I would say overall, the data suggests that there was some benefit in OS with the double checkpoint blockade CTLA-4 plus PD-L1 in combination with chemo. However, I would say I'm not sure those data are actually impacting fully the clinical practice. We have a number of alternatives that are maybe that have already been compared, not with that one, and the benefit as compared to chemotherapy alone had been at least of the same range, if not more. And then the question is there any reason why to give more treatment, like more drugs, and for longer time, as compared to use some other alternatives, unless we see a clear reason for that? So the more important thing would be for me, it is clear that some patients do benefit from intensifying treatment, particularly in the long term. So it would be nice to see how these data are maturing over time. We have seen in other trials with CTLA-4 inhibitors that in the long term, maybe CTLA-4 inhibition plus PD-1 inhibition with or without chemotherapy is worthy. And those data should be further consolidating, particularly in settings such as PD-L1 negative patients.
Okay, thank you very much. I think we have to close this session. I would like to thank all the presenters for their great presentations, their interesting ideas that they put forward. We learned a lot, and especially thanks to Dr. Bazuroy for giving the patient advocate perspective. I think we learned a lot of it. It's the other side. We often discussions with physicians, but also the patients, of course, are our core interest. And I would like to thank all the participants for attending this session and the questions and the interesting discussion we had after the presentations. Thank you and very good night.
Thank you so much, everyone, for joining.
Thank you very much.